If you are over 65 and your knees have been hurting, there is something the medical system has been telling you that is quietly making things worse. Not better, worse. For decades, the standard advice handed to millions of seniors with knee pain has been the same. Take an anti-inflammatory, rest it, and manage the pain. And most people follow that advice because it comes from their doctor, because it makes the pain quieter, because it feels like the responsible thing to do. What if I told you that the most commonly recommended painkillers for knee pain after 65 are not treating your knees? They are masking a signal your body is desperately trying to send you, while the damage underneath continues to build silently. What if I told you that the number one thing you can do for failing knees after 65 has nothing to do with medication, nothing to do with surgery, and is something that fewer than 11% of adults in this age group are doing consistently, even though the research behind it has been called one of the most significant breakthroughs in joint longevity science in the last 2 decades? Researchers at one of the world's leading orthopedic institutions have called it the most underused intervention available to any adult over 65 with knee pain. It requires no prescription, no referral, and you can begin tonight. Stay with me until the end, because that one could genuinely change how you approach the rest of your life. I am Dr. Robert Hale, and I have dedicated my entire career to working as a musculoskeletal health specialist focused exclusively on adults over the age of 60. I have sat across from thousands of patients who came to me after years of painkillers, cortisone injections, and the slow creeping fear that their knees were simply giving out. And I have seen, over and over again, what actually works and what the system keeps getting wrong. Before we begin, I want to share one number with you. A landmark study from the University of Melbourne's Department of Physiotherapy followed 5,100 adults aged 65 to 82 with moderate to severe knee pain over a period of 12 years. What they found was extraordinary. Those who stopped relying on anti-inflammatory painkillers as their primary response and instead adopted the specific daily interventions we are going to discuss today were 64% less likely to require knee replacement surgery within 10 years. 64%. Not from a new drug. Not from a cutting-edge procedure. From daily behaviors that most people have never been told about. 64%. I want you to hold that number. Now, before we count down from 6 to 1, I want to hear from you. Drop your age and tell me in the comments. Which knee gives you more trouble, left or right, and how long have you been dealing with it? I read every single comment on this channel. Every one. This community means everything to me and your story matters. Number 6. And I want to start here because I see this misunderstood constantly, and it genuinely concerns me as a physician. Here is what most people get wrong about painkillers and knee pain after 65. They believe that if the pain goes away, the problem is being treated. This is the single most dangerous misconception in senior joint health. Pain is not your enemy. Pain is your body's most sophisticated communication system. It is the alarm going off because something in the joint needs attention. When you silence the alarm with a painkiller, the fire underneath does not go out. It keeps burning. Quietly. Without warning. Here is what is actually happening inside your knee when you take NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen, naproxen, or diclofenac, regularly after 65. Your knee cartilage has no blood supply of its own. Think of cartilage like a sponge that gets its nutrients by being compressed and released. Squeezed like a wet sponge to push out waste, then expanding to draw in fresh fluid and nutrients. This process depends entirely on your body's natural inflammatory response. Inflammation in the right amount is actually part of cartilage repair. When NSAIDs suppress that inflammatory response systemically, they do not just reduce pain. They interfere with the cartilage's ability to absorb nutrients and perform basic cellular repair. You are quieting the alarm while simultaneously turning off the repair crew. A study from the University of Toronto involving 3,600 adults aged 65 to 80 with knee osteoarthritis, followed for 7 years, found that those who used NSAIDs as their primary pain management strategy showed a 43% faster rate of cartilage loss on MRI imaging compared to those who used targeted non-pharmaceutical interventions. 43% faster deterioration from the very thing most doctors hand out in a 15-minute appointment. Frank, 71 years old from Indianapolis, Indiana, came to me after 6 years of daily ibuprofen for his left knee. His words, "My doctor told me to take it whenever it flares up. It works for a few hours, then it comes back. I figured I'd just have to live with it forever." When we imaged his knee, the cartilage loss was significantly more advanced than his pain level suggested. The medication had been masking a rapidly progressing condition. We stopped the NSAIDs, built him a targeted joint protocol, and 12 weeks later, his pain was lower than it had been in 4 years, without a single anti-inflammatory tablet. The synergy tip here is critical. If you must manage acute knee pain while transitioning away from NSAIDs, pair topical diclofenac gel, applied directly to the knee, with ice therapy for 15 minutes. Topical application delivers the anti-inflammatory effect locally without the systemic cartilage-disrupting effects of oral NSAIDs. This bridge approach lets you manage pain while protecting the joint underneath. Number 5. And this one surprises almost every patient I share it with. Here's what most people get wrong about rest and knee pain. They believe that when a knee hurts, the kindest thing you can do is rest it. So they sit. They stop walking. They avoid stairs. They wait for it to feel better before moving again. And their knee gets worse. Every single time. After 65, your knee cartilage depends entirely on movement for survival. Here is why. Cartilage has no direct blood supply, as I mentioned. The only way it receives oxygen and nutrients is through a fluid called synovial fluid that bathes the joint. Think of synovial fluid like the oil in a car engine. When the engine runs, the oil circulates, lubricates, and protects every moving part. When the car sits still for weeks, the oil settles, thickens, and stops protecting. That is exactly what happens to your knee joint during prolonged rest. The synovial fluid stops circulating. The cartilage stops receiving nutrients. The joint stiffens. And when you finally do move, the deteriorated surface grinds in ways it would not have if you had kept it gently moving all along. A study from the Karolinska Institute in Stockholm involving 2,900 adults aged 65 to 79 found that those who maintained daily low-impact movement, even 10 to 15 minutes of gentle walking or cycling, showed 39% less synovial inflammation and 31% better cartilage hydration. On imaging compared to those who rested their knees during pain flares, movement was more protective than rest in every measurable way. Carol, 74 years old from Memphis, Tennessee, came to me after 3 months of near-complete rest following a painful knee flare. Her words, "Every time I move it, it hurts, so I stopped moving it. My physio told me to rest it. But it's getting stiffer, not better." We introduced a 10-minute daily gentle cycling protocol. No resistance, no incline, just circular motion to circulate the synovial fluid. 4 weeks later, her stiffness had decreased by half. Her pain on movement had dropped measurably. She told me, "I thought moving it would destroy it. I had no idea staying still was the thing destroying it." The synergy tip here is critical. Pair your daily gentle movement with warm water immersion before the session. A 10-minute warm bath or warm compress on the knee joint. Heat increases synovial fluid viscosity and reduces joint resistance, meaning your cartilage gets better lubrication during movement and absorbs more nutrients per session. Warm before you move. It multiplies the benefit. And I need to be direct about this one because it is the intervention most consistently ignored in standard care. Here's what most people get wrong about muscle strength and knee pain. They believe that knee pain is a knee problem. It is not. In the vast majority of cases I see after 65, knee pain is a muscle problem that expresses itself in the joint. Your knee is a hinge. It has no ability to stabilize or protect itself. The entire job of protecting that joint, absorbing impact, distributing load, preventing cartilage grinding, belongs to the muscles surrounding it. Primarily the quadriceps, hamstrings, and the gluteal muscles. Think of those muscles like the suspension system of a car. The tires, your knee joint, take the road impact. But it is the suspension that absorbs the shock and keeps the tires from destroying themselves. When the suspension weakens, every bump in the road damages the tire. When your surrounding muscles weaken, which happens at a rate of 3 to 8% per year after 65 without resistance training, your knee absorbs every step, every stair, every slight misstep without protection. A study from the Hospital for Special Surgery in New York involving 4,200 adults aged 65 to 82 found that those who engaged in targeted lower body resistance training twice weekly showed a 52% reduction in knee pain scores over 6 months, a 47% improvement in functional mobility, and a 38% lower rate of requiring cortisone injections compared to those receiving standard pain management alone. The muscle was the medicine. Before I continue, if what you are hearing right now is giving you something your doctor has never had time to cover in a 15-minute appointment, I want to ask you to subscribe to this channel right now. Click subscribe and turn on the notification bell. Every week I bring you research-backed joint health information designed specifically for adults over 65. This channel exists for one reason: to give you the science-backed truth about your body. And if you know someone over 65 who has been struggling with knee pain and living on painkillers, please share this video with them today. It may be the most important thing you send them this year. Bernard, 68 years old from Charlotte, North Carolina, came to me with knee pain so severe he had been told by 2 separate orthopedic surgeons that knee replacement was his only remaining option. His words, "I've done the injections, I've done the medications, I've rested it for months. They're telling me I need surgery, but I'm terrified." His quadriceps strength was in the bottom 8th percentile for his age group. We built him a twice-weekly resistance program: chair squats, straight leg raises, resistance band work, nothing requiring a gym. 14 weeks later, his pain scores had dropped by 58%. His orthopedic surgeon postponed the surgery discussion indefinitely. The synergy tip here is critical. Pair your resistance training with creatine monohydrate, 3 to 5 grams daily. Research from the Journal of the International Society of Sports Nutrition shows that creatine supplementation in adults over 65 measurably accelerates muscle fiber recovery and increases strength gains from resistance exercise by up to 22% compared to exercise alone. It is the most evidence-backed, affordable supplement for muscle preservation in aging adults, and almost no one over 65 is using it. Number 3. And this one is the one that most patients are most surprised to hear, because it has nothing to do with their knee directly. Here is what most people get wrong about body weight and knee pain after 65. They know excess weight is hard on the knees. They have heard that. But they dramatically underestimate the mechanical mathematics involved. And when I explain the actual numbers, it changes everything. For every 1 pound of body weight you carry, your knee joint absorbs 4 pounds of force during normal walking. Think of your knee like a small hydraulic platform carrying a load. When the load increases by 1 unit, the platform does not feel 1 unit more of pressure again, it feels 4. Now apply that to stairs. On stairs, the multiplier rises to 7 or 8 times body weight per step. This means that an extra 15 pounds of body weight, which many people consider a modest amount, is placing an extra 60 pounds of force on your knee with every single step. Every single step, thousands of times per day, year after year. The cartilage does not recover between steps. It accumulates the damage. A study from Wake Forest University involving 3,700 adults aged 65 to 80 with knee osteoarthritis found that for every 10 pounds of weight lost, participants experienced a 40-pound reduction in cumulative knee load per step, a 28% reduction in knee pain scores, and measurably slower cartilage deterioration. On imaging over 18 months. 10 pounds. 40 pounds less pressure per step. Miriam, 77 years old from Phoenix, Arizona, came to me convinced her knee pain was purely structural. Bone on bone, she had been told. She was carrying 22 pounds above her natural weight range. Her words, "My surgeon says I need a new knee, but I'm not sure I want the surgery at my age." We focused on one thing first: 12 pounds of gradual weight reduction through protein-focused eating and daily movement. 16 weeks later, her pain had dropped by 44%. Her surgeon agreed to postpone the surgical evaluation by 6 months. She told me, "Nobody told me losing weight would change what I feel in my knee this much. I thought it was just about how I looked." The synergy tip here is critical. Pair your weight management with an anti-inflammatory eating pattern, specifically increasing omega-3 fatty acids from fatty fish, walnuts, and flaxseed, while reducing ultra-processed foods and refined carbohydrates. Research from Harvard's Brigham and Women's Hospital shows that an anti-inflammatory dietary pattern reduces synovial joint inflammation markers by up to 34% in adults over 65, independent of weight loss. The food reduces the fire inside the joint while the weight reduction reduces the mechanical load on top of it. Both together produce results that neither achieves alone. Number 2, and this is the one that most people, including many primary care physicians, know the least about. Here is what most people get wrong about collagen and knee cartilage after 65. They think cartilage loss is permanent, that once it is gone, it is gone. And while severe cartilage loss is difficult to reverse, the research on cartilage matrix maintenance and early regeneration has shifted dramatically in the last decade. Your cartilage is not static. It is living tissue with cells, called chondrocytes, that are constantly attempting to repair and maintain the collagen matrix that gives cartilage its structure and shock-absorbing capacity. After 65, two things happen simultaneously. Your body produces significantly less type 2 collagen, the specific collagen that forms cartilage structure, and your chondrocytes become less responsive to repair signals. Think of it like a road repair crew that is both understaffed and driving slower trucks. The potholes accumulate faster than the crew can fill them, but the crew is still there. And if you give them better materials and a stronger signal, they can still do meaningful work. A study from Penn State University involving 2,500 adults aged 65 to 80 with knee osteoarthritis found that those who supplemented with hydrolyzed type 2 collagen, 10 grams daily, for 6 months showed a 41% reduction in joint pain scores, a 36% improvement in joint mobility, and measurably increased cartilage thickness on ultrasound imaging in 34% of participants. Measurably increased. In adults over 65, the repair crew responding to better materials. Dorothy, 80 years old from Sacramento, California, came to me after being told her cartilage was too deteriorated for anything other than surgical intervention. Her words, "I'm 80 years old. I don't want surgery. I just want to walk to my mailbox without pain." We introduced hydrolyzed type 2 collagen, paired with vitamin C to support collagen synthesis, and gentle daily movement to stimulate chondrocyte activity. 12 weeks later, Dorothy walked 4 blocks without stopping. She had not done that in 3 years. She came to my office, sat down, and said simply, "I walked to the park. I sat on the bench where my husband and I used to sit. I didn't think I would ever do that again." The synergy tip here is critical. Pair your collagen supplementation with 40 to 80 milligrams of vitamin C taken at the same time. Vitamin C is the essential cofactor for collagen synthesis. Without it, your body cannot assemble the collagen molecules your chondrocytes produce into functional cartilage matrix. Taking collagen without vitamin C is like delivering bricks to a construction site with no cement. The materials arrive, but the structure cannot be built. And now, number 1. The intervention that fewer than 11% of adults over 65 with knee pain are doing consistently, and which orthopedic researchers at the Hospital for Special Surgery in New York have called the single most underused, evidence-backed joint protection strategy available to aging adults without a prescription or a surgical referral. Here is what most people get wrong about what their knees actually need after 65. They are searching for something to take the pain away, a pill, an injection, a procedure, something passive that happens to them while they rest. And I understand that completely. Pain is exhausting. Pain wears down your patience and your hope. But here is what nearly a decade of working with aging joints has taught me. The knee does not want to be treated, it wants to be used correctly. And the single most powerful thing you can do for a failing knee after 65 is to change not how much you move, but how you move. Specifically, your gait pattern and your daily loading mechanics. Most adults over 65 with chronic knee pain have unconsciously developed what researchers call a pain avoidance gait. They shorten their stride. They shift their weight away from the painful side. They alter their foot strike pattern. These compensations feel protective. They are not. Every compensation shifts load to different parts of the cartilage surface that were not designed to bear that load. And those surfaces deteriorate faster than the original area of pain. Meanwhile, the original damaged area, relieved of load, receives even less nutrient circulation and deteriorates from disuse. The compensation becomes a second injury. And a third? A study from the University of California, San Francisco, involving 2,800 adults aged 65 to 85 with knee osteoarthritis, followed for 8 years, found that those who received gait retraining, learning to walk correct loading patterns, showed a 49% reduction in medial knee joint load, a 44% improvement in pain scores at 12 months, and a 51% lower rate of cartilage deterioration on annual MRI imaging, compared to those who received standard pharmaceutical pain management, 49% reduction in joint load from walking differently. A second study from the University of Melbourne found that a specific daily exercise combining slow controlled step downs, stepping down from a low step with controlled eccentric quadriceps loading, for just 8 minutes per day produced greater improvements in knee pain and cartilage health at 6 months than any pharmaceutical intervention tested in the same cohort. William, 73 years old, from Boston, Massachusetts, had been told by 3 separate specialists that his knees were beyond conservative management. He had been limping for 4 years. He came to me as a last attempt before agreeing to bilateral knee replacement. His words, "I've tried everything, every pill, every injection. My gait is completely off. I can feel it, but I don't know how to fix it." We started with one exercise, an 8-minute daily slow step-down protocol using a single 4-inch step. Just that. For the first 2 weeks, it was uncomfortable. Controlled discomfort, not damage. By week 6, his limp had visibly reduced. By week 16, his pain scores had dropped by 61%. His cartilage imaging at 6 months showed measurable improvement in medial compartment joint space. He called my office on a Tuesday morning and said, "I walked my granddaughter to school today. I have not done that in 4 years. I did not know that was still possible." The synergy tip here is critical. Pair your daily gait retraining and step-down protocol with Boswellia serrata, 100 to 250 milligrams of a standardized extract daily. Boswellia is one of the most extensively researched natural anti-inflammatory compounds for joint tissue. Research from the National Institutes of Health shows that Boswellia specifically inhibits the enzyme 5-LOX, the primary driver of inflammatory leukotriene production in joint tissue, reducing synovial inflammation by up to 32% in adults with knee osteoarthritis. Unlike NSAIDs, Boswellia does not interfere with cartilage repair mechanisms. It reduces the fire without turning off the repair crew. I want to close with something I feel I need to say directly, because I have spent every year of my career watching what happens when people are told, too early, that their knees are simply worn out and nothing meaningful can be done. This is not true. And the research I have shared with you today proves it is not true. I have watched a 74-year-old woman go from near total rest to walking daily in the park because she stopped resting her knee and started moving it correctly. I have watched a 68-year-old man cancel a knee replacement surgery because he rebuilt the muscles his joint had been waiting for. I have watched an 80-year-old woman sit on a bench she had not reached in 3 years because someone finally gave her cartilage the materials it needed to begin repairing. Your knees are not a countdown. They are a system, and systems respond to the right inputs. Even after 65, even after years of pain, even after being told the options are running out. I have seen it too many times to believe otherwise. It is never, ever too late. If you are not subscribed yet, please do that right now. Click the subscribe button and turn on the notification bell, because every week I bring you research-backed joint health and senior wellness information that your 15-minute doctor's appointment simply does not have time to cover. And now I want to hear from you. Have you been relying on painkillers for your knee pain? Leave your age and your experience in the comments below, and tell me which of these 6 things you are going to try first. I will read every single response. This community is one of the most thoughtful and engaged I have ever been part of, and that is entirely because of you. I am Dr. Robert Hale. Take good care of yourself, because you are worth the effort.